Good evening, doctors and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Medical Termination of Pregnancy, Prioritizing Safety, organized by Safe Motherhood Committee of Oxy. So it's my privilege to welcome the MOC of today's webinar, Dr. Sneha Sethumadhavan. Ma'am is the consultant at High Fertility Clinic and Women's Center and also member of Safe Motherhood Committee Oxy. I welcome you, ma'am, and I hand over the session to you.
Thank you so much. On behalf of the Safe Motherhood Committee, I invite all of you to this month's webinar. We are focusing on MTP this month, and I think it's a topic of great importance, not only because it's something that we see very commonly, but also because it is one of the field in medicine which is governed by law as well. Let us start with the Tamil Thai Valthu, followed by the inauguration and lamplighting. I would like to invite our chair of Safe Motherhood Committee, Oxy, Dr. Rajsi, for the Oxy prayer.
Madam, you're not audible.
Ma'am, you are on mute.
Rajsi, ma'am.
Raji, unmute.
Thank you, God. In humility we gather. In gratitude we pray for all the good things you've given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and magnanimity of your endless love. Thank you.
Thank you, ma'am. Now I would like to invite our beloved Oxy President, Dr. Jayarani, to deliver the welcome address for today and also to introduce our chief guest and guest of honor.
Thank you. At the outset, it gives me a great pleasure and honor as a president of Oxy to welcome the chief guest, Dr. M.C. Patel, sir, who is a very great and dynamic person in Foxy, working with a lot of very great commitment and dedications in the Foxy, and had a lot of vision to take this OBGYN into his future charismatic work that he's planning. And sir, it's very great honor for you to be here as the chief guest. I welcome you, sir. And I welcome the guest of honor, Dr. Bharti Maheshwari, who is the chairperson of Foxy MTP Committee, who is the right person to be a guest of honor for this MTP webinar. And a very great welcome to our expert, Dr. Shanti Madam, and all the senior faculties here, Dr. Meena, Dr. Nitya, and Dr. Geeta Lakshmi, Dr. Mahalakshmi, and all the panelists for the panel, Dr. Geeta Lakshmi, Dr. Kartika Prabhu, Dr. Vidya, Dr. Vivek, and Dr. Vijay Lakshmi. And a very warm welcome to all the delegates here. It gives me a great pleasure and honor to be here in this forum of a Roxy Safe Motherhood Committee webinar, which is a very much interesting and well appreciated all over the country. And because Dr. Rajshri is a dynamic person who is working for this committee with every month one aspect of the safety of the mother, which is what she concentrates in her Oxy Safe Motherhood Committee. This time she has the MTP Act, which she wants to make it very clear about the MTP Act. It's what should be done properly and how mothers can be safely taken care on all these aspects of Rajshri. It's really a great pleasure to have this webinar, and she has coined it very nicely with all her experts in this field. And I welcome you all for this webinar. A very special welcome to Sir MC Patil, sir. Can I have Sir CV? Sir, we all were very happy to have you with us, sir. Sir is the Vice President of Foxy in 2018, and he is the consultant of the OBGYN Medical Legal Counselor, who is doing a lot of enormous work on the medical legal aspects for all our OBGYNs. He is the man who has created a uniform consent for all the procedures for our OBGYN practice, which is a very great blessing for all of us to have a safe practice. And also he is a person who is contactable at any time. Anybody having a problem, you can call his line, which he's immediately online to help us to sort out all the difficulties that we face through in any of the medical legal aspects. And we really blessed to have such a senior person to be here in our Oxy forum to be the chief guest for this webinar. Sir is the organizing secretary of AACOG 2017, and he's the chairperson of the Medical Legal and Ethics Committee of Foxy 2011 to 13. And he's the past president of Ahmedabad OBGYN Society between 2010 and 11. And he has been the national president of the National Medicos Organization between 2016 and 18. And he was the organizing chairperson for the Vivekanand NMO Congress in 2017. And he has done a lot of work for the medical legal aspects for all the OBGYNs all over our country. Sir, we are very grateful from our heart of our bottom of our heart to welcome you and deliver your words of wisdom to all our Oxy team and the national delegates here.
Thank you. Thank you, Dr. Jayarani, for kind words. Let me congratulate first OGSSI and Dr. Jayarani in particular for keeping this subject for discussion, prioritizing safety. So, safety is right of any woman during pregnancy, at the time of abortion, and during delivery. So, you have very rightly chosen the subject. And as far as medical termination of pregnancy is concerned, and as far as safety part is concerned, let us put some statistics which are very relevant with this subject. Worldwide, 22 million unsafe abortions every year, and out of those, 7 million every year in India, and almost 50%, and more than 50% rather, happens to be illegal. And rate of maternal death due to complication from unsafe abortion, it ranges up to 8%, and it is third leading cause of maternal mortality rate. So nearly half of the pregnancy related death are in women or girls under 24 years of age. So these problems are related to our young patient, and it is very serious one. In Lancet in 2018, there was very interesting survey, and they came up with 44% of the world's annual 227 million pregnancies are unintended, and out of those, 56% end into abortion, 32% unplanned birth, and 12% miscarriage. And it was also observed that unsafe abortion causes 8 to 11% of global maternal death, and they occur predominantly in lower income or middle lower income group of countries. So these are some statistics as far as this MTP part is concerned. And that is why long back in 1966, one committee was formed in India, that is Shantilal Shah Commission. Because before that, there were so many unsafe abortion, we can call it criminal abortion with unsafe hand. And Shantilal Commission committee was formed in 1966, and in those very committee, 50% were doctors member and other 50% were influenced by Dr. Radha. So MTP Act, when it came into existence, it was doctor friendly. And I would like to mention, in that very committee, one representative from Foxy was also there. And this committee came up with suggestions or recommendations rather, and MTP Act was enacted in 1971. Rules and regulations were formed in 1975, and then after this MTP Act is in action in India. So this is very much need of time, I would say, because whenever any person wants legal abortion, then it should be in safe hand and it should be secret. So MTP Act is for the same. Sorry. So this act was enacted for safety, and three words were actually enacted in that very act, that it is safe, it is legal, and in government services it is free and it is confidential. So with these three words, MTP Act was enacted. And just mentioned by Dr. Jayarani about uniform consent in Foxy. So in those very consent, we have prepared consent for termination of pregnancy also. Because as per MTP Act, we have to take consent in Form C, which is very much mandatory. But it is not informed consent, because in that very Form C, it is simply written, I give my permission to terminate my pregnancy to Dr. So-and-so. So it is not informed consent. So in Foxy website, under banner of Foxy Uniform Consent, it is available. We have prepared for that. So medical termination of pregnancy by medical method and by surgical method. So in this type of cases, you will have to go with two consent. One in this Form C and one informed consent as per available in Foxy website. So with this, again, I would like to congratulate OGSSI and Dr. Jayarani in particular and Safe Motherhood Committee of OXY for keeping this vital subject for discussion. Because whenever this amendment came in 2021, in Lok Sabha, there was very vital discussion about this termination of pregnancy. And there were so many cases before Supreme Court and before Honorable High Court seeking permission for termination of pregnancy beyond 20 weeks of pregnancy. And in most of the cases, either they were victim of rape or minors, or under sexual offense under POXO Act, and there were some congenital anomalies. So government had a very thoughtful discussion in Lok Sabha and Raj Sabha, and then a limit of termination of pregnancy up to 20 weeks was enhanced up to 24 weeks, and beyond 24 weeks also it was allowed with opinion from medical board. So government is also very much keen to see that all the abortion services should be safe. So with this, again, congratulating OGSSI and Dr. Jayarani, and thank you for inviting me to have my expert comments and to be chief guest for this very important webinar. Thank you very much.
Thank you, sir. Thank you for your wishes, and thank you for your kind updates of all about the consent and about the amendment of the MTP Act, which is every gynec practitioner should know, and that is very important in the clinical practice. As you rightly pointed out, we all should be well prepared to reduce the maternal mortality. We are doing all aspects, and this is a very important aspect, that Everybody should take responsibility in looking into the reduction of the mortality by a very simple, safe procedures for the MTP. Thank you for joining us, sir, and thank you for giving your words of wisdom, sir. So now we have
Thank you,
our
sir.
guest
Thank you
of
so much.
honor, Dr. Bharti. Bharti Maheshwari is a very, dynamic person who is working for this MTP committee between 2018 and 20. She has been a governing council member of ICOG, and she is the secretary of the UPCOG, that is a UP Council of OBGYN Societies, and she is the president of the Meerut OBGYN Society, and she has authored and edited many textbooks of OBGYN and books and published a lot of articles on Index Journal, and she has delivered the Kamini Rao oration and other talks in the national and international conferences, and she has organized North Zone and UPOG conferences as an organizing secretary, and she has been the national coordinator of the MTP committee between 2015 and 18, and an executive committee member of the endocrinology committee and public awareness committee and the medical education committee. And today we have here for this MTP webinar, I think she's the right person to talk on the very valid aspects of the MTP Act and the MTP prevalence, because she's the one who chairs the committee, and she'll be the right person to give all the insights about this. Welcome, Dr. Bharti Maheshwari, over to you.
Jaya,
Good evening, everyone,
yes.
and thank you. First of all, thank you,
Bharti,
Dr. Jainani, for
Sir
giving.
is telling.
Bharti,
Bharti, 1 minute, sir is talking something.
Before Dr. Bharti takes over, I would like to say something about Bharti.
Good evening, everyone,
Yes.
and thank you, Dr. Jainani, for giving me this
Bharti,
opportunity.
Bharti, only 1
wait,
minute.
sir wants to say about you.
Only 1 minute. So when she took over office as a chairperson MTP committee in 2018, I was vice president of FOXY, and that very committee was with me. And I have seen Dr. Bharti working all over India with physical meetings, and in era of COVID with webinars also, to work in that very committee to have a safe abortion services all over India. So Bharti is very hard-working person as far as this committee and safe abortion services are concerned. So she is very right person to be invited for this webinar as a guest of honor. Yes, Bharti, go ahead.
Thank you, sir. I was committee chairperson in your tenure, and I always remain your guidance and always inspired by you, by your work and everything. So thank you, Dr. Jirani, for giving this opportunity, all of the society members. And we are glad that you have kept such a important webinar on MTP and all issues. And as Dr. MC Patel sir has said about the data and statistics and how the safe abortion should be done in every cases. So I just want to enhance after that. Then in my 3 years tenure, I came to know that we are very lacking in documentation of related to MTP. So we should be in this coming topics what are going to be in the webinar. I think that would be highlighted, that how the forms should be filled and how the documentation has to be maintained. And beside that, of course, the clinical method in the first trimester and second trimester, we all obstetricians. It is very important to keep updated ourselves so that we all providers can give the safe abortion services to our women. And we should not it's not necessary that only complications occur in unsafe abortion places, but sometimes it can happen to us also. So that is very important, that what methods we should use, what precautions we should use, how consent should be taken. So with all these, I give best wishes for this webinar, and again congratulate whole of the team. Thank you very much.
Thank you, Bharti. Thank you for your nice
Thank you.
words. Thank you so much. Thank you for joining in midst of your travel and busy schedule.
Yeah,
Really, ma'am.
yeah.
Thank you so much, ma'am. Thank you for.
Actually, Jainani madam, आप हमेशा ना 27 बोल रहे थे, but it is today 28. So I was thinking on 28 I am traveling, I can join 27. But anyway, I could join. Yeah, thank you. Thank you very much. Okay.
So every day one event is going on in Oxy. So every
Yeah,
day
yeah.
do one thing. So
Yeah.
support a lot of.
But nice to come in your society. And
Thank
I will
you.
also listen your all topics. I always love to hear about the MTP and all things. Yeah.
Yes.
Thank you so much.
Thank you. Thank you, Bharti. Over to Sneha.
Sneha, yeah, Shanti ma'am.
Thank you, ma'am, for this warm welcoming words. Now, I would like to introduce the expert for today. I'm very honored to have our own senior logician, Dr. Shanti Gunasingh, as an expert for the today's CME. She needs no introduction. She's the past president of OXY and also the Women Doctors Association of Tamil Nadu, and she's held multiple dynamic posts such as Director and Superintendent of IOG and KGH, and she was also the HOD of Kilpack Medical College. She has also secured, she's also served as a Project Director, Center of Excellence for Tubal Microsurgery for 6 years. And ma'am, we are very happy to have you in today's CME. Thank you so much.
Thank you, Sneha.
Welcome, ma'am. We'll start the scientific section, Sneha.
We'll move ahead with the scientific session. So the first on the list is the dialogue on the MTP Act by the dynamic duo, our very own President of OXY, Dr. Jayarani, and Dr. Meena Malingam. Dr. Jayarani again needs no introduction. She's Senior Consultant of Reproductive Medicine and Director of Akash Medical Center, Fertility Center. Apart from being our president, she's also the treasurer of TAPISAR, and she's member of multiple honorable societies and organizations such as ISAR, ASRM, and ESHRI. She's also had many accolades to her name, and she's won multiple gold medals and also been awarded the Best Doctor Award by the MGR Medical University.
Sneha, enough, Sneha.
Okay. Over to Dr. Meena Malingam. She's currently the Senior Assistant Professor of OG at KGH, and she's been the faculty at many national and international conferences and also much loved UG and PG teacher. She's also a member of many OG association and received many also received the prestigious scholarship from IUGA for attending their conference. Over to you, ma'am.
Thank you. Thank you, Sneha. Can I share my screen?
Yes, ma'am.
Thank you, Sneha,
Will
for
be
the
a dialogue,
introduction.
MTP Act, decoded.
Can you see my presentation?
Yes, ma'am.
All right. So I'm
Am
very
I audible,
happy.
ma'am? Am I
Yeah,
audible?
you're audible, Meena.
Thank
Yes,
you,
It
ma'am.
gives me a great pleasure and honor to have this dialogue along with a young dynamic, our Oxyan, Dr. Meena Mahalingam. She's a senior assistant professor from KGH, and Meena has a very passion about all this MTP Act, and she has made it very nicely. And we both will be doing a dialogue today about the MTP Act decoded. So we all know the important facts of a reproductive freedom and justice for a women is to have a freedom to plan a pregnancy, a freedom to have a contraception, a freedom to have an abortion. And all the more for great centuries, this has been a lot of discussion, legalities, legislation, everything has been very much variable about the regulation of this safe abortions. So in this way, there are a lot of ethical dilemmas which are there among the government and the people and the public, and all the more for India. We have a lot of issues related to the ethical dilemma, especially with the culture and the dilemma, traditional and socioeconomic status, and a lot of religious belief that we have. So it is always a very important aspect which has a lot of problem which it involves regarding this problem. So we are here to discuss about an important act which is really a need of every woman safety. So we have to respect every woman's right for their MTP. That's very important in the safest way and with a proper confidentiality, which is a very important one that as an OBGYN practitioners, we should know how we can go ahead legality in this way, and which is very important that we all should know about the MTP Act. So for this sake that we are here. So why this knowledge about the MTP is very important? Because if you look into the data as talked by the chief guest as well as the guest of honor, we know that this, so we know pretty well this is a the data says that every, it is very important, 2 out of 3 of the abortions are performed in an unsafe condition. And it is the third leading cause for the maternal mortality. And nearly half of the unsafe abortions happens for women less than 25 years. That is so pathetic. So young women dying for a reason and for a cause, and that is a leading cause of the third maternal mortality, is really a very, very, very sad thing. So in this way, that very importantly, we all should know when is the abortion considered to be safe. It should be done by an appropriate method. It should be both safe for the patient as well as for the practitioners. And also it should be done by the trained person. So that is a very important thing that we should know about it. So when you look into it, we have to know very many things. So first thing, I just want to ask Meena, we will go ahead with the important thing, that what are the new laws and what are the changes in the law and how we go about it. Before we start, I would like to put in a few things about this MTP amendment, which started right from almost after 2006 law. There has been a lot of revisions in the law, previous MTP law. So this MTP Act, which has been passed in 2021, has gone through a lot of stages. So first to start with, it has a lot of amendments, and then it is pushed as a bill, and then finally came as a law. So we should know that the journey took over nearly 4-6 years for this to be made into a proper way. So we should know about all these criteria which is there in this law. So this MTP amendment of 2011 mainly enact the safety of this law, and we have to have a very closer look as a practitioner to look into the changes that has been made in this law to provide the mother and the baby a safe or respectful abortion care. That's what we call as an RAC. So, Meena, can you tell about the salient features of this MTP amendment of 2021?
Yes, ma'am. So as you have already mentioned, this is mainly to decrease the maternal mortality. So we knew about the previous laws where it states one provider should be there for giving opinion for MTP up to 12 weeks and 2 providers for MTP up to 12 to 20 weeks. The recent amendment states requirement for opinion of 1 registered medical practitioner for termination of pregnancy up to 20 weeks and requirement of 2 medical practitioners for 20 to 24 weeks. And for vulnerable group of women, where we say the women who's affected with rape or incest or who are mentally challenged, the MTP was permissible beyond 20 weeks only when it is immediately necessary to save the life of the pregnant woman in the previous act. The latest amendment states enhancing the upper gestation limit from 20 to 24 weeks for vulnerable category of women, and further enhancement for birth defects not compatible by medical board consensus. And the next is what we think is modification for birth defects and congenital anomalies. The previous law states only up to 20 weeks. Now, the latest 2021 MTP amendment states upper gestation limit does not apply in cases of pregnancy with substantial fetal abnormalities diagnosed by a medical board. That means the medical board can sit and decide on whether the pregnancy can be terminated or not. So there is an increase in access to safe and legal abortion services who often seek services late. Next. And modification related to the previous one, ma'am. For the marital status, the previous, ma'am.
Yeah.
So mainly in the previous act, it was only the failure of contraceptive which was applicable for only married women or her husband. The latest amendment states condition of failure of contraceptive to be extended both for the women as well as to her partner. The potential outcome is mainly increase access to safe and legal abortion for any women irrespective of the marital status. Next. So insertion of new clause for strengthening privacy. So the previous act states the medical termination mentioned that information should not be disclosed except under authority of law. The new law states, name and other particulars of a woman whose pregnancy terminated shall not be revealed except to a person if there is a demand by the legal for the time being in force. That is the main thing. It is the confidentiality and the privacy is very much maintained in the new law, the latest amendment. So prioritizes the confidentiality and safety, name and other particulars of any women seeking abortion to be confidential, except to a person authorized in any law for the time being in force. The ground of failure of contraception has been extended to women under partner. These are some salient points in the latest amendment of 2021.
So that's very interesting, Meena. So you have quoted almost all the salient features of this MTP amendment on 21. Very should be maintained very confidential. It need not be disclosed to the parents or the, if the women or the partner doesn't want to disclose to any of the family members, it should be kept confidential. And it was not like the previous law where we have to inform the relatives. It is not so. So you can keep it very confidential. You need not disclose. And very interestingly, this is a very important aspect that every woman look upon, the confidentiality and the safety, which is very importantly and interestingly. So
Can
the
you
rules,
please enumerate for the rules under MTP, ma'am?
Yeah. So yes, the next comes at the rules of the MTP Amendment 2021. This is categorized of three important ones. One is the special or vulnerable category of women who are eligible for extended gestational period of termination of pregnancy up to 24 weeks. And second, they have given in this amendment the norms of the registered medical practitioner whose opinion is required for the termination of the pregnancy at different gestational age. This is one important thing because every category of the pregnancy, depending on the gestation, has different group or the criteria of the registered medical practitioner, their qualification, whom to give this eligibility, who can decide on this, all has been clearly mentioned in this amendment. And third, it has also given a power and function of the medical board. They have created a board which is even specific for every state, and they should have a mandated rule which has clearly provided in this amendment to make it very clearly for everyone to understand and to work with the power and the functions of the medical board, which is a very important one, which is also very much clearly mentioned in this MTP Amendment 2021. Can I ask, Madam, anything you want to add up, Madam?
No, Madam. That is well understood, ma'am.
Yeah.
Thank you.
So now, as it is, Meena, I would like you to say about what are the rules of the MTP amendment, which is a special category eligible for the women at the MTP. How you look into it? What are the criteria that you will say? Can you define the special vulnerable category of women for this extended gestational period? Tell about it in detail.
Yeah, so we recently have extended the law for special category of women between 20 and 24 weeks, mainly survivors of sexual assault, rape, incest. We do have had 2 cases where the father has had a relationship with the daughter and was brought with the AP eclampsia from a tertiary institute to us. And also women with pregnancy in humanitarian settings, disaster and or emergency situations as declared by government, or when there is a change of marital status during the ongoing pregnancy, whether she becomes a widower or divorcee, she wants to go for a remarriage with a different paternity, or women with physical disabilities where they are not even aware of what is happening to them. That is a major disability as per the criteria under the Disability Act, and mentally ill women, including mental retardation, who require a psychiatric opinion to know the mental status. Their IQ should be also tested, and also minors who are less than 18 years and who do not want to have their pregnancy continued. And also the fetal malformation that has substantial risk of being incompatible with life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped.
Yeah.
Madam, can you please? Yes,
yeah.
ma'am.
So that is actually a very important category that we all should understand. This act extends up to 20 to 24 weeks on the special cases like for the minors, for the mentally ill women, including mental retardation, and on special cases like the rape and the incest, and also for fetal malformations, which has been diagnosed very late in the pregnancy, which also is allowed in this MTP Act. Meena, can you say about what are the norms of the registered medical practitioner whose opinion is required in this special category with a different gestational age?
Yes, ma'am. So norms for the registered medical practitioner to do MTP is very, very important. As per the old act as MBBS or with any medical practitioner assisted in at least 25 cases of medical termination of pregnancy, of at least 5 they should have done independently in a hospital. Or the next is medical practitioner who has completed 6 months of house agency in obstetrics and gynecology department alone, or medical practitioner who holds a PG degree or a diploma in obstetrics and gynecology and who has experience of at least 1 year in the practice of obstetrics and gynecology. So the latest is 1 registered medical practitioner for less than up to 20 weeks and 2 registered medical practitioner for 20 to 24 weeks. And anything above 24 weeks, there should be a team that is a medical board. And norms for the RMP under the latest 2021, there is additional criteria for a provider that is for termination of up to 9 weeks of gestation, whether it is a MMA, medical method of termination, the registered medical practitioner who has experience in the practice of obstetrics and gynecology at any hospital at least for 3 months, or training with performance of 10 cases of MTP by medical method of abortion under supervision by a registered medical practitioner in a hospital, which should be established and maintained, or a training institute approved for this purpose by the government.
So yeah, as you rightly said, so this is the very simple table that you all should understand, that this is a case that for up to 9 weeks, experience of any hospital in the OBG department for 3 months, who has assisted 10 cases of MTP under registered medical practitioner supervision, or assisted 25 cases of MTP and performed at least 5 cases independently, and they must be either a PG degree holder of an OBGYN specialty and 6 months residency as a senior resident in the OBG department for 1 year, and who has been practicing obstetric and gynecology exclusively for 1 year. So up to 9 weeks, these are all the people who are eligible to certify or to do the procedure. So that is what given by the norms. And up to 12 weeks, it should be a postgraduate who has got a postgraduate degree in obstetric and gynecology, or who has to be assisted nearly 25 cases of MTP and performed at least 5 cases independently, and who must be having a 6 months residency in the obstetric and gynec department or 1 year in the practice of obstetric and gynecology. So these are the ones who can do an MTP up to 12 weeks, and beyond 12 weeks, it's the degree postgraduate degree holders or 6 months more residency in OBGYN and 1 year of practice. They can only do it. And these are the 3 criteria. Up to 12 to 24 weeks, they need a postgraduate degree, or they should have a 6 month residency or 1 year practice in OBGYN. So these are the criteria of norms which has been given for the registered medical practitioner whose opinion is required for the termination of pregnancy at the different gestational age. So if you want to still more clarify it, these are the things that you can still more say about it, Meena.
As you've already summed up, ma'am, it's very easy for me. So just need to remember, it is still 9 weeks, the medical method of termination. We need at least 25 cases assisted and 5 done independently, or a degree in degree or diploma in obstetrics and gynecology, or practitioner who has completed 6 months of surgery, house agency in obstetrics and gynecology, or a 1 year practice in obstetrics and gynecology till 12 weeks. The same thing, 25 cases assisted, 5 done independently, any PG degree, diploma, and also where 6 months training has been done, or 1 year in the practice of obstetrics, and beyond 12 to 20 weeks, a degree or diploma on 6 months house agentship or 1 year training in obstetrics and gynecology, and beyond 24 weeks, a degree holder with the opinion of medical board is required for termination of the medical termination of pregnancy or 1 year training in obstetrics and gynecology.
That's very
important.
important.
You, ma'am, tell? Yes, ma'am.
Yeah.
Can you elaborate the rules under MTP and what really a medical board means, ma'am?
Yeah. So we always have to look into the medical board, which is very important, which includes 3 people. One is a gynecologist, another one is a pediatrician, and another one is a sonologist or a radiologist. So the composition of the medical board follows certain suggest points, which are as follows. One is, there should be the head of the department of an obstetric and gynecology of that institution will be the chair of the board. So the board should be chaired by the head of the department. Second, it should involve at least one women member and one member from the government hospital, because even if it is a private institution, it should have one member from the government institution, which is very important. And even if there is a doctor, it includes one lady, women as a person, either the gynecologist can be a lady or a pediatrician or a sonologist. Among the three, one should be at least a women. And then specialists from any other department may be included in the board as per the requirement of the cases. And any board member, if not available at a point of discussion on a case, it should be suitably substituted by another member by the chair. So if the member is recommending some other senior doctor, they can hold the position, but they should ideally have one gynecologist, one pediatrician, and one radiologist to be the board composition. So the power of this board is to allow or deny any termination beyond 4 weeks of gestation period only after due consideration and ensuring that the procedure would be safe for the women at the gestation age, whether the fetal malformation has substantial risk of it being incompatible with life, or if the child when born would suffer from such physical or mental abnormalities to be seriously handicapped. So these are the very important points that they have to note, and they have to co-opt other specialties in the board to ask for additional investigations if required for deciding the termination of the pregnancy. So very importantly, we have to note the FOXI with the ministry guidance and the WHO support as a part of the RAC or the respective abortion care can operationalize the host the medical information on their website. That's very important that we should know. So
can you elaborate on functions of the medical?
Yeah.
Yes.
You tell me the functions of the medical boards, Meena.
So it is mainly to examine the women under reports who would approach for medical termination of pregnancy. So history taking is very important, and also examination and the investigations. Whatever is being given, we need to clearly go through the case notes and provide the opinion of the medical board in Form D with regard to termination of pregnancy, or whether they have given rejection of request for termination within 3 days of receiving request for medical termination of pregnancy. There should not be a delay. If it comes to a medical college, 3 days should be sufficient to make a diagnosis, or just tell them go ahead or don't go ahead. And to ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions, which means it should be done by a trained person and in a trained facility, with appropriate counseling within 5 days of receipt of the request for medical termination of pregnancy. So we need to remember FOXI has an important role to play in ensuring there are functional medical board in every state as stated in MTP Amendment 2021. If not, we need to form the medical board in that particular state.
Yeah.
Madam, can you elaborate?
As you rightly pointed out, Meena, we have to take 3 important salient points here. One is there should be a proper reports examination done by the board, and that should be given within 3 to 5 days. Once they receive the Form D, the Form D is very important. They have to fill the Form D properly, and they should be produced in the medical board, and they have to clearly issue this within 3 to 5 days. And they have to examine all the safety precautions before issuing this. Within 5 days, they should be given a request for the termination of the pregnancy. That's very important. And additionally, they have other related amendments. This amendments which include till 12 weeks, the gestation limit for the approval for the private facilities has been increased. With this change, now we have the following gestation limits for the approval, which can go up to even 12 weeks, 24 weeks, and beyond 24 weeks. Up to 12 weeks, a gynecological examination, a labor table has to be there, and proper resuscitation and sterilization equipment should be present, and the drugs and the parenteral fluids has to be kept in stock, and also all the backup facilities for all these parenteral and the drugs should be there, and there should be always enough facilities for the transportation when it is needed, has to be provided, has to be there present where we are doing this termination. That is very important. And up to 24 weeks, till 24 weeks, a very important OT table, OT performing surgery, everything has to be ready. It has to be there to operate on a gynecological surgery. And anesthesia equipment should be there, resuscitation equipment should be there, and all this sterilization perfection of the theater should be there. and all the emergency drugs and drugs used for the parenteral fluid should be there, which all were given in the government notification should be there present where they are performing a termination up to 24 weeks. Beyond 24 weeks, it should be a very proper OT facilities which should be there to enhance, or all the equipment should be there to handle any open surgeries or laparotomies should be there with proper sterilization, and there should be availability of all drugs, and very importantly there should be a ultrasound machine should be there, which when needed has to be taken for the guidance. So these are the three important I mean, up to this level we have to keep everything ready when we are where we are planning the procedures. So these are the related amendments they have given, apart from a routine who has to do, when, how it has to be done, how it has to be certified by the medical board, and where it has to be done. For all these safety things, they have given a very clear amendments in the newer ones. Meena, can you say a few things about all the nutshell, in a nutshell, how you want to make it up?
Yeah, we want our mothers to be saved. We want to reduce the maternal mortality and morbidity due to illegal and unlawful abortions, and also septic abortions, where the previous days the quacks used to keep even the legs of the chicken. So we need to avoid making MTB, which is available in the public as well as the private sector, and not motivate the women to come to the facility instead of going to sub-centers where the facility is not available. So in India, we want the abortion to be legal. Let us make it safe and respectful. As Madam has already told, it's a comprehensive abortion care. It should be a respectful abortion care for our Indian women. So what they state is Samarth, that is sustain, accelerate mainstream access to reproductive health through health. Thank you, ma'am.
So with these words, we thank one and all for the for patient listening, and thank you, Meena, for joining me in this dialogue. Thank you.
Thank you, ma'am.
Madam Shanti, Madam, for your expert.
Yes, ma'am. Shanti, ma'am, for your. Thank you so much, ma'am. Meena and Jairani, madam. Thank you.
Thank you, President ma'am and Rajshri ma'am and Team Oxy for the opportunity.
Yeah, it was an excellent dialogue by Dr. Jairani and Dr. Meena. It was very comprehensive, and all aspects of respectful abortion care has been covered very well. And the woman's consent alone is enough if she is more than 18. But if she is less than 18, we have to get the consent of the guardian too. And POXO Act will come into play then. That we should always remember. And but MTP Act overrides POXO Act. So if they have come for abortion, then in that, if they do not want to disclose, both, and if the person is a minor, both if the person as well as the guardian clearly state that they want MTP, but they do not want to disclose, you have to inform, but need not inform the finer details of the person. So that is very, very important. And the most important thing is we have to fill up all the forms. Even in so many established nursing homes, people do not fill up the form. Consent form, of course, is always filled up, Form C. But then Form 1 should be filled up within 3 hours of termination, initiation of termination. That is very important. And monthly statement is also not sent routinely in some places. So that will come under Form 2. And we have to keep all these statistics for about 5 years. That is Form 3 from the end of the calendar year. So suppose you have done in Jan 2023 also, then from December to 2023, 5 years. So any time authorities can ask, but only authorities can ask for clarification, not others. And the disability, Meena nicely said, it is major disability. So not a minor disability at all. That we should remember. And MMA, that is medical termination of pregnancy by medical methods up to 9 weeks. This can be done in an unapproved site. So you need not have permission to do it. But then you should have access to referral. That should be there. That is very, very important. And we should also understand that once we get approval, no need for renewal at all unless some problem occurs. So all these things are, we should be really very conversant with the law and abide with the law. And also we have to give good care to our women who demand MTP. So thank you very much, Dr. Rashmi, for having given me an opportunity to share my thoughts. Thank you.
Thank you so much,
Thank you,
ma'am.
madam.
Thank you so much. There are no questions. We will move on to the next session. That will be by Sneha, our young enthusiastic member, and it will be on first trimester MTP, what we need to know. Sneha? Yes.
Thank you, ma'am. Thank you so much. Good evening, one and all. Thank you, Oxy, for this wonderful opportunity. This is a small presentation on what we really need to know about first trimester MTP. I would like to start by saying that in India, the decision to terminate pregnancy voluntarily is still not the right of the women. MTP laws differ from one place or one country to another. And in our country, we have a very concise MTP law which tells us when, how, where, and who has to perform this. So when is it legal to terminate? As we had already seen in the previous presentation, to quickly recap, this is only when the mother is at risk or life-threatening or grave physical or mental injury, or when the child is going to get affected by a major physical or mental handicap, on a humanitarian basis, if the pregnancy is as a result of rape, or if there's failure of contraception. As Dr. Shanti correctly said, the consent form needs to be signed duly, Form C, and if the woman is more than 18 years, woman alone is enough to give consent, irrespective of the marital status, as we have seen through the amendment in 2021. Or if the woman is a minor, if it's a child, then a guardian who is going to take responsibility needs to sign. And here again, the POCSO law comes into act. But the POCSO law says that MTP can be done in good faith for the girl, and you just need to inform the authorities, and there's no need to file an FIR unless the involved person really wants to. This can be performed in a government setup as well as private setup, and as the NHM says that depending on the week of gestation, the place, even in government setup, the level of care changes. So if it's less than 8 weeks, the PHC can do it as long as it's a low risk patient. 8 to 12 weeks CHC or a 24/7 PHC, but if it's more than 20 weeks, a district level or tertiary care center is required. If it's in a private clinic or a hospital, it needs to be approved by the government or district level committee, and it can be performed up to 24 weeks with a proper license, and Form B certificate of approval is required. And as Dr. Shanti correctly said, documentation is very important. It starts with Form 1, which is the opinion form that needs to be given by the doctor. So up to 20 weeks, one doctor's opinion is enough. Form 2, which is the monthly reporting form that needs to be sent to the government authorities. Form 3 is the admission register, which needs to be kept for 5 years. And Form C is the consent. All this is only for MTP. If you're going to do the procedure for a missed abortion or an incomplete abortion, a routine consent form like in any other surgery and routine OT notes is enough. Now, as a gynecologist, as a provider for safe MTP, we can split this into 3 pauses: the pre-MTP phase, the MTP phase, and the post-MTP phase. Let's start with the pre-MTP phase, where the woman comes to us. So we need to review the indication if at all she fits into any of the legal reasons for termination, and take a brief history. This is mainly to make sure if she has any medical conditions or severe medical conditions, which would help us to decide whether medical or surgical treatment is more apt for her, and also to see if admission is required. Previous uterine surgeries, but usually in first trimester, there's no need to change the dose if she's had a previous uterine surgery. Any history of allergy, a bare minimum of investigations such as baseline hemoglobin, blood group, and serology, ultrasound, The NHM and also GOI says that it is not a must, but if you have the facility, it can help us to differentiate if it's an intrauterine or an extrauterine ectopic, and also to assess the gestational age correctly. And now we need to counsel the woman on what MTP is, what kind of methods are available, and what she can expect out of the process. Coming to the actual MTP process, as we all know, there are two main arms. Medical, which includes the dual drug mifepristone with misoprostol, and the surgical method. WHO now says MVA is the preferred method when compared to other methods such as DNC or DNE. And WHO also says that both can be offered up to 12 weeks, but we need to talk to the woman the pros and cons of each method so that she can make an informed choice, and also look at her medical and surgical risk factors as well. Medical has a success rate of around 95 to 98, but she might have to come for multiple visits. But there's no need for admission if she's a low risk case, and no need for anesthesia as well. Surgical, the success rate is slightly higher, especially if you're doing it under ultrasound guidance. A single visit is enough, but you'll have to admit the patient and administer anesthesia. Starting with the medical method, now we have MTP kits, which makes it very easy to explain to the patient. So on the first day, you explain to the patient, ask her to give consent and provide her with the mifepristone 200 mg, which can be swallowed orally. Anti-D is a controversial topic. Some guidelines says for less than 12 weeks, we are supposed to give 50 microgram IM. Others says for less than 12 weeks, only if you're doing it by surgical method, we need to give anti-D, but when in doubt, better to give. So 1 or 2 days later, 24 to 48 hours later, day 2 or 3, you can ask her to come back and provide her with misoprostol 800 micrograms, which is the 4 tablets, which can be swallowed orally or kept under the tongue for it to dissolve, or kept as a PV. Another method is buccal, but it's a very erratic release, so it's not usually suggested. Certain guidelines like WHO, FIGO, and GOI, lot of regimens are given by lot of societies, and some organization even says that we can repeat the dose at 2 to 3 doses at 3 to 12 hours interval. It's better to give the patient some antiemetic and pain medications. And if you're sending her home, we need to make sure that she understands what her red flag signs are, especially if she has heavy bleeding. That is, if she changes more than 2 pads an hour for 2 consecutive hours, and provide her with the 24/7 contact number. 15 days later, you call her back for a follow-up to examine her and to make sure that it's completely been expelled. This is a nice card that's provided by the government for MMA, medical method of abortion, where she can have a calendar. She can tick as to what are all the symptoms that she's experienced. And as you can see, they've also provided with the red flag signs, such as excessive bleeding, or if she's not started bleeding within 24 hours, or if she has signs of infection as well. Coming to the surgical method, which is MVA, I'm concentrating more on MVA because this is being suggested as gold standard by WHO. It can be employed up to 12 weeks, and it's known to cause lesser complication when compared to DNE. It's less traumatic, and the cannula size will be, you can use the cannula size which is corresponding to the gestational age of the pregnancy. The anesthetic, you can give an oral NSAID 30 to 60 minutes before the procedure, or a paracervical block or IV sedation. And antibiotics is very important in surgical case to prevent sepsis later on. So you can give, one regimen is where you give doxycycline, which needs to be started 1 day prior and continued 5 to 7 days after the procedure. Post MTP, you call her back 14 to 15 days later, around 2 weeks later. This is to make sure that she does not have any heavy bleeding or signs of infection, and examine her clinically. If you have an ultrasound, you can also do an ultrasound, but ultrasound is very non-specific. In case if you're suspecting retained products, there might be thick endometrial thickness of more than 15 with blood flow. Another, if you're in a low resource setting, you can even do a simple urine pregnancy test to see if there's retained products. This is a very important point where you need to educate the patient on contraception so that such event does not happen, or she can avoid unnecessary pregnancy in the later period. Talking about contraception, just a small slide to summarize what we can offer when. because after abortion, we do not exactly know when she starts ovulating again. Literature says after medical or surgical, it might take anywhere between 10 to 20 days for her to start ovulating, and her cycles may get delayed a little bit. So this is a very dangerous period where she can conceive again without getting her next periods. So if you are going to do the abortion by medical method, OCP can be started on the third day itself. That is when you are providing her with the misoprostol, or on the 15th day when she comes back for the review. DMPA injection can be given along with the misoprostol tablet. Copper T is usually on the 15th day when she comes for the follow-up, and this is only after confirming for sure that she's completely expelled the entire products of conception, and also after ruling out any signs of infection. Tubal ligation is usually postponed till after the first cycle of the MMA. Coming to the surgical method, because most of the time you're confirming that you're completely evacuated, you can start OCP or DMPA immediately. Same goes with copper T after making sure that there is no injury, retained products or infection. And tubal ligation can be done concurrently or within 7 days of post-abortion. So with this short presentation, I would again like to stress on the point that safe abortion care is very important. And as a gynecologist, I think we have a very important role to provide this service to our patients. Thank you so much.
Excellent presentation by Dr. Sneha. It was aesthetic too. The slides were also very good and it was very comprehensive. And we should understand that our MTP law is really very liberal. Need not be a OGian, even 1 year in the practice of OG. They can provide all these care. And when we give medical management, she nicely stressed about the failure rates. But we should also tell them that 1% can go in for surgical evacuation due to heavy bleeding, and 2 to 3% will need surgical evacuation due to incomplete expulsion. And as she said nicely, when in doubt, give anti-D, because that is really a life-changing procedure. So I think we have to give anti-D, especially when you are going in for miscarriage later in gestation. So well done. And when we are giving, see in that chart what Dr. Sneha had put, that is about fever and chills. Even when you're counseling for medical management, you will tell them that with meso, you will have fever, rigors, then pain abdomen, nausea, vomiting, all that. So that itself will really help them to face the situation very well. Thank you very much.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank you so much. We will move on to the next. Excellent talk, Sneha.
Thank you, ma'am. We'll go to the next speaker. We have Dr. Nitya with us. She's going to be talking on second trimester MTP. Over to you, Dr. Nitya. Can I have the CV, please?
Dr. Nitya is a consultant at MMM.
Sorry, Dr. Nitya is consultant at MMM Chennai. She's also a member of Safe Motherhood Committee, OXI, and her special interests are high-risk obstetrics and reproductive medicine. Over to you, Dr. Nitya.
Yeah. Good afternoon, one and all. I would like to, sorry, are my slides visible?
Yes, ma'am.
Yes. Okay. Thank you. Thank you, ma'am. Good afternoon, one and all. I'm here to talk about MTP second trimester and beyond, when, what, and how. Understanding the MTP law, I think after hearing from Dr. Jairani ma'am and Dr. Meena ma'am and a recap, from Dr. Sneha, I think I don't have to elaborate on these anymore. So we can directly move into the second trimester. Okay, so second trimester abortion. So what are the things that we should be doing? So first would be the history taking, a general physical examination, bimanual abdominal vaginal examination, a pre-procedure counseling, and pre-investigations, which would minimum require a hemoglobin, urine routine, and blood grouping and typing. Prophylactic antibiotics should be kept in mind, and RH isoimmunization, contraception, and follow-up. So the first thing that we should be thinking about in a second trimester abortion is it necessary for a fetal demise prior to the abortion process? In 2010, clinical guidelines on these topic from the Society of Family Planning concluded that the current evidence does not support the use of induced fetal demise to improve the safety of dilatation and evacuation. With medical abortions after 20 weeks of gestation, induced fetal demise may be preferable to the women or the provider in order to avoid the transient fetal survival after expulsion. Now, based on the limited evidence, induced fetal demise before medical abortion may shorten the induction time. But we don't have enough evidence on this. Now, coming to the methods of medical abortion. Now, in the second trimester, now we have certain methods. One is the medical abortion. Second one is the surgical. And the third one is non-surgical methods. Now, coming to the medical methods, Dr. Sneha had clearly told us about how do we do it when it is less than 12 weeks. Now, talking about medical methods when more than 12 weeks, so we have a combination regime or a misoprostol only regime. So a combination regime would be by giving a 200 mg mifepristone orally, followed by 400 micrograms of misoprostol, either given vaginally or sublingually or buccally every 3 hours. Now there should be a minimum gap of at least 24 hours to 48 hours between the mifepristone and the misoprostol. Now, it is told that a vaginal route is usually a better option and a combination regime is preferred. Now, when mifepristone is not available, a misoprostol only regime can be used, where repeated dose of 400 micrograms of misoprostol should be administered vaginally, sublingually, or buccally every 3 hours. When using misoprostol beyond 24 weeks, we don't have enough evidence or data on how much dosage has to be given. Now, in this, a clinical judgment is needed. Now, this should be based on the patient's history, patient's comorbidities, patient's previous uterine scars, and reducing the doses of misoprostol and by increasing the duration between the doses is mandatory when giving a misoprostol beyond 24 weeks. Now, this was according to the WHO Abortion Care Guideline 2022. Now, what does the RCOG say? Now, there's not much difference between these. It's just that in the RCOG 2022 best practice guideline, it says mifepristone of 200 mg is given, followed by misoprostol of 800 mg stat is given, followed by 400 mg every 3 hours till abortion is over. So the same way, more than 24 weeks, increased interval between the meso doses and lower doses, especially with the uterine scars. Now, what does the RCOG recommend? ACOG recommend? This says that 200, this is something similar to the RCOG, where the mifepristone 200 mg tablet is given, followed by misoprostol of 800 mg, followed by 400 mg every 3rd hourly. But this includes the word that a maximum of 5 doses can be given. Now, this can also be given buccally. If mifepristone is not available, misoprostol alone can be given with 400 micrograms, and then we can give up to 5 doses every 3 hours. So if misoprostol also is not available, so they advise that oxytocin of 20 to 100 units infused intravenously over 3 hours, followed by 1 hour without oxytocin to allow diuresis. Now, oxytocin dosage may be slowly increased to a maximum of 300 units over 3 hours. However, this regimen is not frequently been used. Now, if abortion process is not completed after the 5 doses of the misoprostol, we can give a gap of 12 hours and then restart the whole process again. Mifepristone followed in 24 to 48 hours by misoprostol is the most effective regimen, and it has an efficacy of about 91%. Now, this is recommended by the FIGO 2017. So this is when it is more than 13 weeks to up to 24 weeks, 200 mg mifepristone followed by 400 micrograms of misoprostol every 3 hours, which is similar. Now, coming to abortion in a case of intrauterine fetal demise. Now, here it suggests, WHO suggests a combination regimen with mifepristone with misoprostol, the similar with the 200 mg of mifepristone followed by 400 micrograms of misoprostol every 4 to 6 hours. So this is when the gestation age increases, we need to understand that we have to increase the interval. Misoprostol is safer in inducing second trimester abortions, and it is better to use it vaginally because it produces a shorter induction to abortion interval, and sublingual can be given for a patient who wants to avoid multiple vaginal administration or when there is heavy bleeding. Misoprostol, it is to be understood that misoprostol is still not an approved method for termination of pregnancy in the second trimester in India. It is not approved. But although we have enough evidence from the international guidelines, misoprostol has been commonly used in India as well. Use of 200 mg oral mifepristone before a prostaglandin can increase the abortion rate and shorten the induction to abortion interval. Gimiprost is a licensed drug for this purpose, but however, misoprostol is a safer alternative. It is to be understood that when there is a patient with severe cardiac disease or a valvular heart disease, coagulopathies, allergic to medications, uncontrolled asthma, chronic renal failure, mifepristone will not be given. However, misoprostol can be given. Coming to the adverse effects, we see it ranges from abdominal pain to uterine cramping, nausea, vomiting, diarrhea, backache, fever, and also they have seen in the trials between the US trial and in the French trials that these are the common adverse effects. Coming to the pain management in a medical abortion, now WHO abortion guidelines suggest that NSAIDs can be given, and we can suggest antiemetics and epidural also if available for more than 12 weeks. Coming to the non-surgical methods, extraamniotic instillation of ethacridine lactate. Now, this is a safe method of second trimester abortion with an efficacy of 95%. Now, instilling 0.1% of ethacridine lactate through a Foley's catheter inserted transcervically in an extraamniotic space. Now, this has a direct effect on the myometrium. It causes separation of the membranes and prostaglandins are released. This is contraindicated in renal disease and placenta previa. However, instead of ethacridine, we can also use a hypertonic saline, urea, or a prostaglandin or oxytocin also. The other method is an intraamniotic instillation of hypertonic saline by just putting in a needle, like how we do it for an amniocentesis. Hypertonic saline can be infused. Now there's a contraindication where renal or cardiac or anemia is there. We should not be doing this because of the excess sodium overload. Severe mortality has been observed due to hypernatremia. Coming to the pain for surgical abortions more than 12 weeks, we suggest cervical priming prior to the procedure for abortions more than 12 weeks before a surgical abortion. Now, between 12 to 19 weeks, it's WHO suggests that a cervical priming along with the combination of mifepristone with a misoprostol can be done, or an osmotic dilator with the medication can be used. Now, but make sure that the placement of the dilator and the procedure should not exceed more than 2 days. For surgical abortion more than 19 weeks, it is recommended that a cervical priming is needed with an osmotic dilator with medications of mifepristone and misoprostol or combination of both. Now, what are these osmotic dilators? So these are hygroscopic materials which will swell up by observing the cervical and the vaginal secretions. They gradually dilate and stimulate the contractions. A minimum of 4 hours is needed to be effective. Advantages is that it will reduce the chances of the tears and the hemorrhage. But the disadvantages, it can lead to infection. Coming to the surgical abortion, we have dilatation and evacuation, which is more commonly done between 13 to 16 weeks of pregnancy for mid-trimester abortion. Prior to cervical dilatation, it is better to use any osmotic dilators with a medication combination. A long forceps with a vacuum aspiration cannula can be used. Curettage is an absolute method, and it is better we do it with ultrasonic guidance in the second trimester if ultrasound is available. Aspirotomy, it is between 14 to 20 weeks. The procedure involves initial slow dilatation with the laminaria tens or the misoprostol, followed by rapid dilatation. The fetal parts are grasped, crushed, and removed in pieces, better done with ultrasonic guidance. Hysterotomy, it is done rarely, although when patients have more than 2 cesarean scars, or when there is a placenta previa with heavy bleeding, or there is a vascular lesion or a CA cervix having massive bleeding, hysterotomy has been done, and also done when all the other medical methods have failed. Now, coming to the pain management in surgical abortion, NSAIDs are recommended. WHO says a recommendation against general anesthesia. We can use a paracervical block or a combination of conscious sedation with a paracervical block for a surgical abortion for more than 14 weeks. And management of incomplete abortion when the uterine size is more than 14 weeks, medical management can be done using misoprostol every 3 hours. Or if we're going for a surgical abortion, do it with antibiotic prophylaxis. Isoimmunization, RH isoimmunization, Dr. Sneha had clearly told us that different guidelines have different opinions. So just to be on the safer side, it is better to provide anti-D in less than 12 weeks. But more than 12 weeks, it is recommended to give anti-D. Coming to the antibiotic prophylaxis, again, various guidelines have different opinions. So the WHO abortion guidelines is a majority of them say that for a medical abortion, there is no need for any antibiotic prophylaxis unless the patient is at high risk of any infections or there is any evidence of PID. Then antibiotics are not needed. But for a surgical abortion, it is better to go for a antibiotic prophylaxis, and the most commonly used antibiotics will be metronidazole, doxycycline, or penicillins are effective. Usually, or doxycycline 100 mg twice a day for 3 to 7 days within 2 hours of the procedure can be given. The complications of second trimester abortions, we can have immediate complications like systemic toxic reactions, hypersensitivity, and allergic reactions. Delayed complications like incomplete abortion, failure of the procedure, of sepsis. During the procedure, we can have hemorrhage, infection, perforation, cervical injury, hematometra, broken plastic cannula, or a syncope. And the remote complications can be cervical injury, chronic pelvic pain, Asherman's, obstetric complications, and psychosomatic complications. And this is a little note about the post-abortal hemorrhage, which is usually faced after a second trimester abortion. So what we can do is dilatation and evacuation is the preferred method. Use of vasopressin in the paracervical block may reduce the blood loss. We can also give methyl ergometrin. Misoprostol is an effective agent. In refractory bleeding due to atonicity, a Foley's catheter or an intrauterine balloon can be given for a tamponade. And post-procedure, women should remain in the healthcare facility for at least 4 hours. Patient should be in the recovery room and all her vitals have to be monitored. And we have to address infections, sexually transmitted disease, anemia, and so domestic violence, contraception. Discharge details have to be given. Suppression of lactation is important in second trimester. The cabergoline of 0.5 mg per oral, and pain management and antibiotics, and schedule her follow-up within 2 weeks. And post-abortal contraception, Dr. Sneha had already covered this topic on contraception. So any mode of contraception is can be suggested to the women depending on her wishes, but a note on contraception will be mandatory to be shared with the women at discharge. Thank you, ma'am.
Thank you, Nikia, for your comprehensive talk. And the second trimester MTPs, you talked about oxytocin. We used to give lot of high titer oxytocin earlier. So we have to keep on increasing the dose. And they used to deliver, it will take a long time, pain will be there. But then now all that is gone because we have better drugs. And not only that, we usually say with 100 units of oxytocin, we can have a complication of water intoxication. Yes. So 300 means you should be really very wary of giving oxytocin. So I don't think we will be using that much. And 12 hours, that gap is essential if the MTP fails. If it fails to proceed, as you nicely said, at least 12 hours gap is mandatory. And then if you reinitiate, in that event, we do not start MIFI. Only the meso is given. And IUD also, because it might be, we do not know when the IUD has occurred. There might be some additions, all those things. So as you nicely said, instead of every 3 hours, you will be giving it every 4 to 6 hours. As UGs and as PGs, we had used extra amniotic saline. We used to give 150 ml extra amniotically, or even IAS, intra-amniotic saline. But all that is gone now. And osmotic dilators, we used to use then. And we used to, so many times it will fall off. Sometimes infection will result. So many things are there. But Dilapan now they say is very good even for abortion as well as even for labor. Yes. So it was comprehensively covered. Thank you very much.
Thank you, ma'am.
Thank you, Shanti ma'am. In spite of your busy schedule, having another program, you logged in, and yes, your expert opinion was really, I think you've cleared all the doubts that people had also, ma'am. And yeah, shall we move on to the...
Yes, ma'am, we'll go on to the last session for today, which is the much awaited panel on MTP in special situations. For this, we have two moderators, Dr. Geeta Lakshmi and Dr. Mahalakshmi. Dr. Geeta Lakshmi is presently senior consultant at KJ. She's a passionate teacher and she's the treasurer of OXY. She's also presented various papers in national and international conferences, and her area of interest is high-risk pregnancy, adolescent health program, and medical educator. Dr. Mahalakshmi, she's currently the assistant professor of KJ Chennai. She's a recipient of AL Mudaliar Travel Fellowship, published a paper in various international journals, and also has done a formidable service in the rural areas by actively participating in many medical camps. Can I introduce the panelists? We have Dr. Geeta Lakshmi. She's the consultant at Lifeline Hospital, Chennai, and she's currently pursuing fellowship in reproductive medicine. And she's a member of multiple OG societies and also secured multiple awards for paper presentations in national conferences. We have Dr. Kartika Prabhu. She's currently the professor of SRM Medical College. She's won multiple gold medals and awards, Dr. Asha Bakshi and Dr. A.V. Umachigai gold medal, to name a few, and many publications to her name, and she's active faculty at many conferences. Dr. Vidya is the associate professor at Department of OBG in Balaji Medical College. She's a very skilled laparoscopic surgeon and academician. Dr. Vijay Lakshmi. She's currently the professor and head of Department OG Chettinad Medical Hospital. She has vast years of teaching experience, and she is also the president of IMA Velachery. Her area of interest is high-risk obstetric, adolescent gynecology, subfertility, and endoscopy. Over to the moderator. Sorry. I forgot the most important person who has so much expertise in the legal aspect. Dr. Vivek Madi, sir, he is the consultant director of RK Malathi Hospital. He was the past honorary secretary of IMA North Chennai and also the president of KMC Association. He's the legal expert for us today, and he's completed multiple law-related degrees from various prestigious institutions in India. Over to the moderators. Thank you.
Dr. Geeta Lakshmi, sorry, she is the Joint Secretary of OXY currently, and recently she has been promoted as Associate Professor, Department of OG in Chengalpet. Welcome, Geeta Lakshmi.
Thank you.
Take over the panel.
Thank you, Dr. Rajashri. Am I audible?
Yes, yes. Mahalakshmi is also there.
No. Am I audible?
Yes, Geeta Lakshmi, you are audible, you are readable. I'm not seeing Mahalakshmi.
Mahalakshmi is there, I think.
Okay, fine. Okay.
So, a very good evening to everybody. It gives me an immense pleasure to be a moderator for this panel on MTP in special situations. I first of all thank the Safe Motherhood Committee of OXY, especially Dr. Rajashri, the chairperson, and I welcome Dr. Mahalakshmi, my co-moderator, and I've got eminent panelists here to answer my questions. So this is a very interesting topic, and throughout from 4 o'clock, you've been hearing about medical termination of pregnancy. And it was a good highlight by all the speakers, and I think if you had listened to Dr. Jayarani Kamaraj, our president, and Dr. Meena, it was a very good highlight on the methods of medical termination of pregnancy and how to go about beyond 24 weeks of gestation. So we are here to speak about the MTP in special situations. Maha? Yes. So to go on with the medical termination of pregnancy, as highlighted before, this act was put in 1971, and it was done for various reasons like therapeutic, eugenic, humanitarian, social, and environmental. So therapeutic, when the woman's life is in danger if pregnancy to continue. Eugenic, when there is a risk of child being born with serious physical or mental abnormalities. Humanitarian, pregnancy caused by rape. Social, when the failure of the contraceptive methods occurs in a married woman. And environmental, when it is a poor economic status which affects the mother or the child health status. Next slide. So, to introduce, a medical abortion is brought about by taking medications that will end the pregnancy or terminate the pregnancy. Alternatively, for the medical, there is a surgical method which ends the pregnancy by emptying the uterus with instruments. Before 1971, abortion was purposely something like causing a miscarriage. In 1860, according to the IPC under the British rule, induced abortion is illegal. Abortion practitioners would either be incarcerated for 3 years or fined or both. So women would be imprisoned up to 7 years and also be fined. The only exception was abortion done to save the women's life. So, to go about the definition of a medical termination of pregnancy, medical termination of pregnancy is a procedure that uses medication or surgical procedures to end a pregnancy, and the MTP Amendment Act of 2021 provides for extending of the MTP from 20 to 24 weeks, and that is the concern now, and under supervision of the medical board in cases above 24 weeks of gestation. So today we are going to go with case scenarios on MTP in special situations. So the salient features to understand are termination of pregnancy up to 20 weeks due to a failure of a contraceptive method or device allowed for all women, including unmarried. Upper limit increased to 24 weeks for certain categories of women. Confidentiality clause, section 5A, has been introduced, and violation is punishable by law with the imprisonment up to 1 year with fine. Approval from the state medical board for termination beyond 24 weeks for substantial fetal anomalies. So this is the introduction for the medical termination of pregnancy. And to go on to the special situations, we have case scenarios, we have expert panelists, and we have got our legal advisor, Dr. Vivek Maddy, who's here. And for each of the case scenario, sir, we are going to ask sir whether there is any other point that can be added to that. So welcome, Dr. Vivek Maddy.
Thank
so
you.
Now we go on to the first case scenario. A 24-year-old Mrs. Nayan, second gravida, para 1, live 1, has done her anomaly scan at 20 weeks of gestational age. Then she went to her native place for her brother's marriage, and she came to the OPD at 25 weeks of gestation with an anomaly scan report for a regular checkup. The scan reports show bilateral renal agenesis. So what are we going to do next? Dr. Vijay Lakshmi Kandasamy, can you just highlight on what we can do for this patient, what best we can do for this patient?
Thank you, madam. Am I audible?
Yes, Vijay.
Yeah. Yes. Thank you for the opportunity. And as you have said, this is a second gravida who has had her anomaly scan and reported to us almost a month later. And
Yes.
she has definitely crossed the period of 24 weeks, which is as per the revised norms, which is eligible for a termination, which we can offer her. But the only thing is the condition that the fetus has, bilateral renal agenesis, is definitely a lethal condition and not compatible with life. And so we have to counsel her, and we should definitely put across the case to the district medical board. And I'm sure, as our previous speaker said, every district has the medical board, and they will come out with a judgment that we can go ahead with the termination in such a case. And yes, that we have to definitely work and work fast. That is very important, because she has already crossed 25, she's crossed into her 25th week. So the medical board, which will comprise of the senior obstetrician, a pediatrician, neonatologist, and a radiologist, and a psychiatrist, as well as a genetic counselor, because we should be advising her about the future chances also, now that we face with a case of bilateral renal agenesis, which is definitely lethal.
Yes, Vijay, very nicely said. And for the sake of the delegates, I would like to repeat that whenever there is a lethal anomaly in the fetus and the termination is beyond 24 weeks, the medical board consists of the obstetrician, neonatologist, and the counselor, psychiatrist, and radiologist to decide about the termination of the pregnancy. Sir, would you like to highlight anything, any point, Dr. Vivek, sir?
Yeah, I'll see the reason why you have put 24 weeks is it is a period of viability. See,
Yes.
by law, we are all supposed to save lives. But then the fetus after 24 weeks is supposed to have life. So it is not right for us to take out any life as as doctors. So a fetus after 24 weeks cannot be terminated. The only case we can terminate is if it has such a substantial anomaly that it cannot be born alive, or if it's born, it can have very serious handicap. Only that reason is the only time we are allowed to take the life of the fetus.
Yes,
So
sir.
that's why you have this 24 weeks. 24 weeks is the time when a fetus gets a right to live. Okay.
Yes,
So
sir.
24 weeks is very important.
So thank you, sir.
So two things you have to remember: 24 weeks. Whenever you see a person, when you see a pregnant lady, see the gestation. If it is beyond 24 weeks, you have to make sure that the fetus is having a very serious anomaly. Otherwise, you cannot take out this fetus.
Okay, sir. And the mode of like medical termination of pregnancy can be carried out by induction
Yes.
of elective
Yes,
abortion according to the FIGO regimen.
Yes,
It has
yes.
been recommended that
Yes.
only misoprostol 200 micrograms can be given by various routes, like it can be per vaginal, it can be subcutaneous, sublingual, or buccal, and it has to be repeated every 4 hours. So this is the mode of termination when it crosses beyond 24 weeks after getting the consent from the medical board. So now we go on to the case scenario, and I would like Dr. Mahalakshmi to go on with the second scenario.
Yes, ma'am. So the second case scenario is a 23-year-old Miss Deepika. She is a primary, a sexual assault survivor, visits your clinic asking for terminating her pregnancy at 12 weeks of gestational age. She has not revealed this to her family. She doesn't want to tell this to her family as her mother's health condition is not good, as she suffered from heart disease. How are you going to proceed? Dr. Vidya Selvam, can you answer this question, please?
Yes, madam. This patient, Deepika, is 23 years old. So she is a major, more than 18 years. So she has all the rights to, ask for termination of the pregnancy. And this is a case of sexual assault. And she doesn't want it to be revealed to her family. So as a doctor, to maintain the confidentiality with the consent we can provide. She's only 12 weeks. So one single medical practitioner opinions enough to go on with the termination of pregnancy. So with the patient request, we can go on with the termination of pregnancy.
Yes, ma'am, rightly said. So I would like to repeat, that is, under the MTP Act, pregnancy arising by rape can be terminated on the humanitarian grounds. Since this client is a major and she insists on confidentiality, the doctor need not inform the police. The confidentiality of the client must be maintained and she doesn't want to reveal the details to her family. So the doctor can go ahead with the termination of pregnancy as per the MTP law.
But, madam, I just would like to have a clarification from Vivek, sir. Since she is saying that it has resulted from rape, do we have any, are we duty bound to at least not inform the police with her details, but at least say that that's something like this has happened? Because, it is like allowing the perpetrator to go scot-free, and we just offer, and this perpetrator of the sexual assault may continue to, go scot-free. What is the law on that, sir?
See,
Can we
yeah,
not?
see the only under POXO Act, it says that if the person is less than 18 years, we are supposed to inform the police. There's no other law that says. When it is above 18 years, it's up to the person who's been insulted, who's been raped, for them to give a complaint. And if they complain, if the police comes and asks for details, it is for us to document everything and give the details. So in the case of if somebody says rape, it's important as a doctor, we keep all the documents very safely. It can be even after 2 months, 3 months, anytime they can ask for the details. So if you have a rape case, it's very important that you keep all your documents very safely. And also, it's important. Another thing is the conceptus. It has to be kept in saline and given for DNA examination if necessary. So this is very important. Now, it is not mandatory for us to report the police because
Not mandatory. Okay.
yeah, it is only if it's POXO. If if it is minor, that's it. If the person that wants to keep it confidential, it's up to them. They don't want to go through the hassles of going to the court, and they know who the rapist is, and sometimes they'll just keep it confidential. But it's always better for us to get a letter from the person, not to inform the police.
So there is a question from the chat box. They are asking whether we have to make a AR entry for this.
Yes, you have to. The rape means you have to enter it in. That's why I say your record should be safe. It's not necessary for you to go and the law doesn't say that you have to go and report to the police, but you have to keep your documents safe. If it is, you have to enter in your records. But anytime they can come and ask you the police. So you have to take the precautions.
Made and the
Yes.
police asks you for some report.
Yeah,
Then
you have to give it. You have to. Yes, you have to give it. You are bound to give all your records when the police asks. If you say you don't have records, then you're liable for a punishment for not giving the records.
Okay, sir. Okay. Thank
So
you.
that's very important. You have to keep the records. That's why I said. And even the material concept is better to get it sent for DNA analysis or to confirm the pregnancy.
Okay. So we'll go to the next scenario. This is a 26-year-old Mrs. Barbara, primi gravida at 6 weeks of pregnancy, has come to your OPD for a booking visit. She's a known case of rheumatic heart disease, severe mitral stenosis with pulmonary hypertension, on cardiac drugs since 16 years of age. So what are you going to do? Dr. Geeta Lakshmi, can you highlight?
Good evening to one and all. Ma'am, can you able to hear me?
Yes, ma'am. Continue.
As she is a primi gravida and she's taking medications from 16 years of age, and she's having a pulmonary hypertension with severe mitral stenosis. She is a contraindicated for becoming pregnant, according to her history, ma'am.
Okay.
So we should discuss with her regarding the pros and cons in this continuing the pregnancy.
Okay.
So we should give a detailed counseling to her regarding for the termination of pregnancy.
Okay.
Because the mortality with this is like 25 to 50% if she's having all comorbid severe hypertension, severe pulmonary hypertension with mitral stenosis. So a proper counseling for termination of pregnancy is to be mandatory for this patient actually.
So what other causes do you think like a heart disease patient has to get terminated? Other than mitral stenosis with severe mitral stenosis with pulmonary hypertension, what are the other conditions, cardiac conditions?
In case of like severe mitral stenosis, other than like pulmonary hypertension, like she's having if she's having Eisenmenger syndrome, or she is having like said to be like class 3 or class 4 according to NYHA, and if she is having like cardiomyopathy, and if the ejection fraction is less than 45, definitely the pregnancy is contraindicated.
So very nicely said that the other cardiac conditions are severe aortic stenosis, severe mitral stenosis, severe pulmonary hypertension, cyanotic congenital heart diseases, Marfan syndrome with aortic root involvement, and it can be a HOCM, that is hypertrophic obstructive cardiomyopathy, and when the patient falls under the NIHA class 3 and class 4. So
and one thing, ma'am, in Marfan's, like it is autosomal dominant, so the chance of like spreading to the offspring is almost like 50%. So
yes, ma'am. So suppose if this patient you are going to terminate, so what are all the precautions that you're going to take, and how you are going to approach the termination?
So because she's a contraindication for pregnancy. So it depends upon like a multidisciplinary team approach. So as a logician, along with the cardiologist and the anesthetist and a counselor should be involved for the termination of pregnancy, because the proper counseling has to be given to the patient to carry out MTP.
So you mean to say that should be a close communication and coordination
it's a
between all
teamwork,
the team
approach.
members, like the obstetrician, cardiologist, anesthesiologist, the psychologist, and you need a counselor before you do the MTP, such that the patient is having a good outcome as you are conducting the medical termination of pregnancy. So that has been highlighted in this slide. Okay. So always it is said that in a woman with a rheumatic heart disease, oxytocin and prostaglandins, need to be used in caution, and they can cause severe uterine contractions that may be too strong, which may lead to increased cardiac output in patients with a rheumatic heart disease. So the healthcare team may recommend alternative methods of management. And in the government setup, we are really thankful to the cardiac registry, which has been maintained at RGGH, So the cardiology team, they work in conjunction with the obstetrician and gynecologist, and we are able to do such kind of medical terminations of pregnancy with caution, and also conducting the deliveries also, it has been made very easy by the cardiac registry, which has been maintained by the cardiologist in the government setup. So very nice highlight by Geeta Lakshmi that a heart disease patient, how to go about, when to terminate, and what are the other conditions you have highlighted very nicely. So we'll go on to the next case. And this is a 28-year-old Mrs. Uma who has been diagnosed to have tuberculosis. She has now come with a UPT positive report. The transvaginal ultrasound was done, and she was found to be 10 weeks plus 3 days. She visits our clinic for advice on whether to continue or to terminate the pregnancy. What would be the appropriate advice and further management? Dr. Kartika Prabhu, can you highlight on this?
Since we have to find out a detailed history and find out on what drug she is on.
Yes.
So the regimen so depends upon the drug. So mostly the first line drugs can be allowed to continue during pregnancy. So certain drugs like ethambutol, drugs which are not safe in pregnancy, then you have to counsel and terminate. So first you have to take a detailed history regarding the drugs she's on.
So nicely said, Kartika. Eliciting a detailed medical history is an essential part of the management. See, we work in government as well as we have private clinics. So wherever we are, the detailed medical history is very important. The symptoms need to be elicited to find out if it is a pulmonary or extra pulmonary. And we have to go through the patient's medical records. And the drug regimen, as rightly said by Kartika, the patient on first-line drugs can be allowed to continue her pregnancy without any major adverse events. But a patient on second-line drugs need to be counseled for termination of pregnancy. Next slide, Maha. So, Kartika, can you just tell me what are all the tubercular drugs which are contraindicated in pregnancy?
So patients on streptomycin, kanamycin, fluoroquinolones, ethanolamide, those drugs are all contraindicated. So amikacin, which belongs to category drug, can affect the fetal auditory system. So fluoroquinolones and ethanolamide can cause damage to the articular cartilage of the fetus and can cause defects in the CNS also.
Yes, we have to categorize the drug, and category D and C can cause lethal effects. So these drugs are contraindicated in tuberculosis. So therefore, the client needs to be counseled regarding the termination of pregnancy. And if she is on second line drugs, since the client's gestational age is 10 weeks, we can opt for the medical termination of pregnancy with the opinion of one registered medical practitioner. Is that okay, sir? Maddie, sir?
Yes, you can go ahead.
Okay, sir, right. So we'll go on to the next case, and I think Maha will continue with this case.
So now this woman, she is 22 years old, Mrs. Monal. She is a primee coming from Gujarat. She is a known case of sickle cell anemia. Her electrophoresis shows HbS, and her husband is having sickle cell trait. During her pre-pregnancy period, her obstetrician at Gujarat advised for chorionic villi sampling in the early pregnancy. Meanwhile, her husband got transferred and she comes to your clinic with a chorionic villi sampling report which revealed sickle cell anemia for the fetus. Now she wants termination of pregnancy. What would be your advice?
Maddie,
no,
sir, can you highlight?
Yeah, see, what we are trying to say here is a sickle cell anemia is not a very serious problem for us to sit and ask for termination. So we should first counsel her that it's not necessary. It can be corrected at any point of time. Only thing that termination with misoprostol is contraindicated because it can cause sickle cell crisis. So only thing that is the important part in this case, that it's very important we inform the patient. Somebody having a sickle cell anemia is not a contraindication, is not an indication for terminating the pregnancy. They can have some other thing, but it is not an indication. It is a treatable cause, because what they need to know is how you get sickle cell disease. As in this case, once in only if the husband and wife are both are having the trait, then only there's a 25% chance of the child having the sickle cell disease. While if both of them are having the sickle cell trait, 50% chance is there. What we are trying to say is, it's not a very serious disorder that is necessary to terminate the pregnancy. But
Yes,
she
sir.
can have some other reason. That's okay. But as
So, but in this case,
Vijay,
see, I think,
Vijay, what is your opinion?
Madam, in this case, see, actually, the mother has trait and he also has, and they have a serious report which says that the fetus is positive. So I think we have to, if the pregnancy is under 12 weeks, or maybe she has got her CVS, so she just crossed into the second trimester, probably. And I think, should probably take the parents' wishes into consent and offer her a termination if they are really insistent upon it, because as you rightly said, though it is not a lethal anomaly, if they are below 20 weeks of gestation, when it is okay for us to offer, having the condition themselves, and they know how much of a limitation it is on their lifestyle and on their life, and there's repeated chances for the sickling crisis and poor quality of life. So then probably we should respect the wishes of the parents and offer termination if they are insisting on it. But
So
we
do
have
you
to
think
really
she will
counsel
have
them.
a healthy pregnancy, Vijay?
50%. The main thing is let us get a psychiatrist to counsel them, and I would say that
with
it is
trait,
left
we
to
have
them.
managed pregnancies, but with
Yes.
sickle cell disease, it is a little, the pregnancies are not so good, the outcomes. They do go in for fetal growth restriction, and sometimes they can also have an intrauterine demise. So all that risk factors are there during the course of her pregnancy. So I think we have to definitely counsel her appropriately.
Yes, Maha, you can highlight what you want to say about this case.
Yes, ma'am. So in this case, the probability of having a normal child is 0% because she's having sickle cell anemia and her husband is sickle cell. So 50% of children will have sickle cell trait and the rest 50% will have sickle cell disease. And again, it is a high-risk pregnancy. So if she is going to terminate this pregnancy, so there is probability of having a like
All
if she's
these, yes.
continuing this pregnancy, she is a high-risk pregnancy and she will have a premature delivery or pregnancy-induced hypertension, increased rate of cesarean section, and increased incidence of PPH, and also maternal death is also a possibility in the intrapartum period. And again, fetus is also at high risk because low birth weight, IUGR, and ABGA score is low at 5 minutes, and probability of stillbirth is also low, very high. And intrapartum fetal distress is very common in these cases. So we have to counsel her adequately because she is already living with a sickle cell anemia. So when she is able to lead a healthy life, when she is able to bear a child, and this child can also be healthy. So we have to counsel her adequately. And also in subsequent pregnancy also, she cannot have a normal child. She can have either a fetus with a sickle cell trait or a sickle cell anemia.
Disease.
So
Yeah.
that's why
We
I'm
have to
saying,
counsel her. And in spite of adequate counseling, if she insists on termination, we have to take adequate precautions and terminate this pregnancy. So as Sir said, highlighted earlier, misoprostol is a medicine which is contraindicated for terminating pregnancy in sickle cell disease because it causes increased risk of sickling crisis and also increased risk of fetal hemoglobinuria. So this can exacerbate the sickling crisis and increase the risk of renal damage. So use of misoprostol should be avoided in this termination of this pregnancy.
Okay, Maha, it was a good highlight about the sickle cell disease. And in a women with the sickle cell disease who are considering termination, again, it is a multidisciplinary approach. With the obstetrician, anesthetist, and the hematologist, we have to go about the MTP. So can we go on to the next scenario, Maha?
Yes, ma'am.
So this is a 22-year-old Mrs. Navya, married for 6 months, sustained a road traffic accident while traveling to her native place. She was rushed to the hospital and trauma series X-ray and CT scan was taken. She was discharged after a week, after which she realized that she had missed her periods. Scan done now shows 6 weeks viable pregnancy. So what are we going to do? Dr. Vidya, madam, is there?
Yes, madam.
Yes, madam.
Okay, ma'am. Actually, up to 6 weeks, up to 6 weeks, the radiation exposure, we have studied that it will cause all or none effect. That is, if it is going to have severe anomalies, it will result in abortion, miscarriage. And if it is not going to affect, we have to, but anyway, it will be the baby is exposed to high risk radiation. We have to counsel the mother, madam, that there is a risk of exposure to radiation. And so we have to do proper anomaly scan with the fetal medicine specialist. If there is there's no anomaly detected, we have to counsel the mother regarding the risk of exposure to radiation, the in utero life, what other side effects like a risk of blood cancers in the newborn period. We have to explain that, and if she goes on to continue the pregnancy with the informed consent, then we can continue pregnancy.
Okay, Dr. Vijay, would you
Yeah.
like to?
But the modern CT scan or probably the X-rays and all that we take, the machines are very highly, their doses of radiation exposure is very minimum. So I think, and as Vidya madam said, it is an all or none. If the fetus has been exposed to an embryotoxic dose of radiation, it is going to spontaneously abort, or we are going to have a missed miscarriage. And she's very early in pregnancy. So I think we have to counsel her appropriately that way. And if she has a viable pregnancy which continues, and when we are able to see that at the NT scan that there are no major anomalies, then we can always counsel her positively, saying that you're likely to have a fetus which is unaffected by the radiation. So we should give her that option. And it's very, very important that we use the positive counseling, because many times you find that when women are exposed to a single dose of X-ray for some reason, either foot X-ray or whatever, they come back asking for a termination of pregnancy. So, and the radiologists generally say that the radiation exposure is very, very less with all the modern machines.
Yes, rightly said, Vijay. So it depends upon the gestational age as well as the dose of radiation. So that is the point to highlight. So large radiation doses to the fetus during the most sensitive stages of development is between the 2nd week and to the 18th week of pregnancy, which can cause birth defects, especially to the brain. Therefore, the anomaly scan at 20 weeks need to be carried out to rule out any fetal anomaly is there. However, in the absence of any anomaly, unborn babies are especially sensitive to cancer-causing effects of radiation. However, the increased risk depends upon the amount of radiation to which the baby is subjected to and the amount of time it was exposed to. So that is the point that has to be highlighted. So the teratogenicity, the exposure is less than 5 rads and it is not associated with congenital anomalies, as Dr. Vijay said, that it depends upon the exposure. And the oncogenicity, the exposure in the first trimester is associated with the increased risk of malignancy. And probably the genetic damage does not occur. And the chances of IUD with the low dose radiation definitely does not occur. So as Dr. Vidya Madam said, it is a all or none phenomenon of radiation exposure in pregnancy, which refers to the concept that embryonic exposure that occurs before organogenesis results in either no adverse embryonic outcome or embryonic death. So this concept has been extensively used in the genetic counseling of pregnant women who have inadvertently undergone an exposure in the very early stages of pregnancy, frequently before the pregnancy has been recognized. So what is a 10-day rule? No women should be exposed to an X-ray for non-urgent indication outside 10 days from her last period during the reproductive period. So the absorbed radiation from the fetus by the fetus in the different diagnostic radiation procedures has been given here. As far as the abdominal X-ray is concerned, the dose is 0.2 rads. Pelvic X-ray, it is 0.5 to 1.1. And chest X-ray, it is less than 0.001. Abdominal CT, it is 0.5 to 1.1. And ventilation lung scan, it is 0.004 to 0.019. So this table shows you the radiation dose limits for the fetus during pregnancy. So the radiation hazard and the dose is given for various conditions like permanent sterility, embryonic death, maximum permitted dose of the fetus for a pregnant women, total gestational dose equivalent to, and the risk of the congenital malformations developing in the malignancy after radiation in utero. See, it is as less as 0.2%. So that is the risk. So this is the highlight of when a patient is exposed to radiation. You always have to think about the gestational age and the amount of radiation that she has been exposed to. So we'll go on to the next scenario, Maha. I think you will go about this.
Yes, ma'am. So this case, she is a 34 years old Mrs. Amuda. She is a known case of invasive ductal carcinoma operated. While she was on chemotherapy, she got pregnant. She comes to OPD at 12 weeks for consultation. How will you proceed with this case? Ma'am, Geeta Lakshmi, ma'am, can you?
Yes, ma'am.
Yes, ma'am.
Because she has this thing, a ductal carcinoma, for which now she is pregnant. So actually, the chemotherapy drugs seems to be cytotoxic. So proper counseling regarding the chemotherapy agents has to be discussed with the patient, ma'am. So for that, the proper counseling is a must for the patient. Ma'am, can you able to hear me?
Yes, yes, ma'am. Yes, ma'am. Yes, ma'am.
So what adverse outcomes can occur because of the chemotherapeutic drugs, Geeta?
It will affect the this thing fetus only, ma'am, basically.
Yeah.
Because it is said to be the cytotoxic drugs. It will not only affect the usual cells. It will no, it will also affect the normal cells too. So proper counseling should be given for for MTP basically, because it's said to be cytotoxic, which will affect the fetus.
Okay, ma'am.
So,
yeah, this is actually a real case we had in KGH. So she opted for MTP, and we induced her with the multiple methods. We had Foley inserted, then we gave misoprostol, then we gave her rest for a week period, then we repeated misoprostol, but she didn't get any pains. Then finally, one day we did a rupture of membranes, after which she expelled the fetus. But after that, the great, untoward event happened, and placenta didn't come out. And we have to take her to OD. And we tried removal under anesthesia. And to my shock, I was a duty obstetrician. It was a morbidly adherent placenta. And later we had to go and refer our textbooks and other journals which was published. And we came to know that when the woman becomes pregnant with she is on a chemotherapeutic agent, there is a higher incidence of morbidly adherent placenta. And then we had to proceed with an emergency hysterectomy for this patient. So
yeah, so this actually has had a very bad outcome for the patient, isn't it, madam?
Yes, ma'am.
And it is a very sensitive case as well. She's going through a diagnosis where we have to, she is on multi-drug regimen, chemotherapeutic agents. And I think the earlier counseling should be that we should have addressed the contraception issues probably and spoken to her about other pregnancy prevention, so that this would not have, she might not have landed up with this kind of a situation where she had to lose her uterus.
Yes.
And I think as a gynecologist, when we start treating women, especially more and more we see women with breast cancer and earlier ages in their mid-30s and all, this possibility of pregnancy is always there. And when they're on chemotherapeutic agents, appropriate contraceptive counseling has to be advised for these women. And it's a very rare cause or very rare, actually, morbidly adherent placenta when the patient is on cytotoxic chemotherapy. So,
can any of the panelists highlight if the patient is on hormonal therapy, what you would do?
Yeah, so that's it. Like as you say, trust to Subha ma'am. If she's continuing this drug, at least 7 months, she should be with a contraceptive advice not to become pregnant, because there is a chance of congenital anomalies even on chemotherapeutic drugs. So to avoid that, a contraceptive advice should be there, and that's why nowadays we are thinking of fertility preservation. If somebody is going to take chemotherapy, there is a possibility that her eggs can be taken out and cryopreserved. So that is a possibility. Before you start chemotherapeutic agents, fertility preservation option should be given to her. Ovum pickup and preserving it, preserving is an option today, which is available in a lot of centers. So if she desires to have a baby, that's the best method before you start chemotherapy. Once you start chemotherapy, there's very less options.
Yes, sir.
Mahak, for the sake of the delegates, please explain, like when the patient is on chemotherapy and hormone therapy, what do we do?
So whenever we have a young woman presenting with the carcinoma and when she started on chemotherapy, adequate counseling should be given regarding the contraception method and which would be safe for her when she is on chemotherapeutic agent. And also, as sir highlighted, fertility sparing methods should be enlightened to the women. And if she is opting for that we should proceed with that, and we should adequately counsel her that she should not become pregnant, and also we should explain her the anticipated complications if she is getting pregnant while she is on chemotherapy or hormonal therapy.
Shall we move on to the next scenario?
Yes, ma'am. So
I
this
think
case,
this is also a case from KGH. I think you can go about it, Maha.
yes, ma'am. So now she's admitted at KGH. She is a 26 years old, Mrs. Ranjita. She is Gravida 3, Para 2, Live 2, previous 2 LSCS. Comes to your clinic at 22 weeks with a scan report showing placenta accreta. She demands MTP. How will you proceed? Dr. Karthika, ma'am.
So placenta accreta, it can actually, the invasion of the placenta can proceed as the gestational age advances. So if patient is opting for MTP, we can proceed with that, but we should be cautious because bleeding will be more. And so pre-op embolization, bilateral uterine artery embolization should be planned. And patient should also be counseled that if not possible to do termination, she may end up in hysterectomy.
Okay, ma'am. Ma'am, how will you approach this client if she is not willing for hysterectomy?
Because it's always a concern, patients don't, they don't give consent for his hysterectomy. Then what would you do?
You will refer to another doctor, I think.
That's a nice
Madam,
answer.
the one thing is she has 2 live children. She's a third gravida. She has come into her second trimester. And I really feel that, the option for the MTP, she should have thought about it in the first trimester. We really do not know what has brought her to this level, to the up to 22 weeks, and then to demand an MTP. But considering the reproductive choice of the woman, if she's really desirous of and very insistent upon having a termination of pregnancy, then we should consider and counsel her appropriately, because there's a very high possibility of going ahead with either an in situ hysterectomy or trying to do bilateral uterine artery embolization, which in some way may fail sometimes, but sometimes she can get lucky. But most of the time we see that or we have to give her the option of going ahead with the pregnancy and then probably do a cesarean section and proceed with a peripartum hysterectomy also, which we usually see and do most of the time. When it is depending on the degree of the accreta that we are seeing, whether it's partial focal or whether it's a complete accreta spectrum that we're seeing, or what is the degree of or is it a percreta? All that we have to see. At this stage in pregnancy, we may get off if we are lucky, and if she is lucky, by salvaging the uterus, saving her uterus. If it is a
Would you
focal
agree with your
adherence.
panelists?
Yeah, see here, there's a clause that in case of risk to life, so Krita is a risk to life. She can bleed to death. So in that case, at any point of time, if you find that it is she's necessary to termination is necessary, termination can be done. There's no question on that. And I think so. The hysterectomy is a good option if she wants to have. But then if she doesn't want to have an hysterectomy, yes, your methotrexate can also be offered to her as a so that it can come out. Placenta.
But yeah, the reports are not very good when leaving the placenta in situ and exposing her to a lot of infection. And
yes. In that case, yes, that's why counseling is very important.
We invariably end up doing a delayed hysterectomy if you do, if you do not do it at the same sitting where you would do a hysterotomy at that first stage.
So that's why it is counseling is very important in this case. Whenever there's accreta, counseling is important.
Okay, sir. Yes, Maha.
So in this case, actually, we have proceeded with, we have done a uterine artery ligation, uterine artery embolization. Then yesterday morning, we proceeded with hysterotomy, and the procedure was uneventful. To our luck, I think the placenta got separated as a whole. So we proceeded with sterilization. Suppose if the placenta is left in situ, the main thing is we should not proceed with permanent method of sterilization in this case.
Definitely. that's a total contraindication for us to
Yes,
do
yes, ma'am.
sterilization. Yeah, and you were lucky, as I said many times, in the mid-trimester, sometimes we get away. Though the radiologist might give you a diagnosis as accreta, sometimes we see that the placenta separates when we're doing the hysterotomy.
Yes, ma'am. Ma'am, shall we go to the next
Yes,
case?
ma'am. It's a very nice case that you have. It's a real case which you have given. Okay. So next slide. We'll go to the case scenario 9.
Yes, ma'am.
So this is a 20-year-old Mrs. Priya, married since 9 months and is now 32 weeks of pregnancy. Her husband dies of alcoholic liver disease and her family wants to get her remarried and does not want to continue the pregnancy. Maddie, sir, can you
that's
tell us
what I
what
said.
we
No,
could do for this patient?
yeah, that's what I meant, because it's beyond 24 weeks. She does not have any right for it to be terminated. If at all she wants, it has to go to the court. The court will decide. They'll make a medical board, and the medical board finds the baby is not having any congenital anomalies, which is incompatible with life. They will not allow.
Yeah. So this does not satisfy any of our clauses for MTP, because we have a viable fetus and she's probably, and now she's into 32 weeks of gestation. So
No, that's what
I think
she has to find out if the baby is incompatible with life, having an anomaly or not. If she's not having an anomaly, she has no right to them.
Okay, sir. So any case of abortion beyond 24 weeks, it is only by the through
medical board.
the High Court hearing, and the medical board only decides under these kind of specific circumstances. And the MTP amendment provides for the constitution of the medical boards to the approved facilities which may allow or deny the termination of pregnancy beyond 24 weeks, sir. So since in the present scenario, the relatives are not willing for the continuation of pregnancy, the mother's choice is one of the which we should take. Since a patient is 34 weeks pregnant and the fetus is normal, the medical termination of pregnancy is not advised at all, and as the pregnancy has crossed the period of viability. So she can wish to continue her pregnancy, and at a later, she can decide to give the child to the Child Social Welfare Committee. But through this committee, none of the direct relatives of the mother can claim any rights over the child. Maddie, sir?
Yes, I agree. Because nobody has. It is the child of the mother. The mother has full rights for the child, and she decides she wants to continue to have her relationship with the child or not.
No, sir, but I supposing when she gives up her right to the child and she gives it up to the social welfare services, child social welfare services, she has to forego her biological right to the child and has to give it across for adoption.
No, at any point of time, she can always take it back. It is her baby before it is taken for adoption. It's her baby.
No, but before.
Yeah,
but
before.
if she gives up the baby for adoption, then she is giving up her biological right.
Right.
Isn't it? So the law is
once
she has to give.
Yes, but she might change her mind at any point of time, and she wants to have a baby before being adopted. She can have it.
Yeah.
Before the baby is getting before she getting out.
It's only the mother's right.
The mother's right, and not anybody else. It's her baby.
Okay.
That nobody can deny. Yes,
considered.
It's her baby. Yes, her baby.
Yes, sir. So this is a interesting fact which we have just highlighted for the case of the delegates. A similar case scenario which was presented in AIIMS. Delhi High Court has directed the medical superintendent of AIIMS to constitute a board to examine a 20-year-old woman seeking to undergo termination of pregnancy at 26 weeks. In her plea, the woman submitted that she got pregnant through a consensual relationship, but she came to know about the pregnancy only recently. Her counsel contended that the woman said that she did not realize that she was pregnant earlier, but when she started facing some medical issues and consulted a doctor, she came to know that she was pregnant. However, when she expressed her wish to terminate the same, doctors pointed out her advanced condition. Seeking the court's intervention, The women's petition said that she was not in a condition to bear the child, but the doctors refused to terminate the pregnancy since, sir, the slide, I think, is missing. Maha?
Madam, I think the courts will probably rule against her only because the pregnancy has crossed into 26 weeks, and she's not falling under any of the clauses. It is just that she has not diagnosed her pregnancy so far. The similar case was reported even in Maharashtra sometime back when the courts, ruled against the woman for when she opted for termination. And even in Kerala, very recently, we had such a case where the courts refused, refused to offer her the choice of termination when the pregnancy has crossed into the early third trimester.
Yeah. So this
See
case
what's
was,
happening. Mahalakshmi has lost connection.
Pardon?
Screen sharing is not
happening. We are not able to share the screen. Maha is there? Maha?
Sahiti?
Yes, ma'am.
What's happening? Mahalakshmi is not there?
Ma'am has left the webinar, ma'am. Maybe ma'am has got disconnected.
Okay, then if Maha is out of thing, we can go on to the next case. So, and this is the last case probably. A 21-year-old. We have time now, Rajashri?
Yes, we have time.
Yes, please connect Maha.
Screen share பண்ண முடியுமா? You can share.
I'll try to do it by my screen. Share screen. Okay, then I'll just read out the question so that the panelists can answer. It is a 21-year-old Mrs. Saranya. She has learning difficulties since childhood. Her caretaker noticed the girl's increasing abdominal girth and has taken her to the nearby hospital. On taking the ultrasonogram, she was found to be pregnant. She has been sexually assaulted by an unknown person. And since Saranya is not in a sound mind to take care of a baby, the caretaker wants to terminate the pregnancy. Sir, how would you go about with this case, sir?
Yeah, see, here this is a non-consensual pregnancy. A person with learning difficulties cannot give consent to sexual act. So therefore, it was without her consent, this pregnancy has taken place. So this is a crime. So this
equivalent to rape.
Yeah, it's equal to rape.
It's
so
a rape.
In this case, it is better to inform the police and terminate the pregnancy and give the conceptus to the forensic lab for finding out the culprit and taking action. So that is the only way, because in this case, yes, see, earlier what you said was the rape was in a major who can give consent. Like a previous case, I think you have given a case of a rape in the beginning for a major girl who had a sound mind. If she if in a sound major, if they don't want to report to the police, then it's okay. Then it's not duty of the doctor to report. But in this girl, she doesn't have a sound mind. She cannot take any decision for herself. So for that, the duty is on the doctor to protect the patient, and therefore it is the duty of the doctor to report to the police, and the police will take action to find the culprit who's responsible for this crime and give punishment. And we as doctors, we should help in terminating this pregnancy. Definitely a person with disabilities cannot look after a child. She can't look after herself. How can she look after a child? So therefore, the option of termination should be given to them, irrespective.
So Vijay, can you just highlight
so before deciding on how much her retardation is, send her to a psychiatrist. She get a full assessment of her psychiatric condition. So this again is a multidiscipline approach. You get her mental score, IQ score, and if the score is below average, then definitely we should help her to and take a decision for her, protect her, and terminate the pregnancy.
Thank
Sir,
you.
as per
Anything
today's
would you like
law,
to highlight, Madam Vidya, Madam?
Madam, as per even today's law for sexual assault victims, mental illness, women with mental illness, the cutoff decision is only 24 weeks. Sir. After 24 weeks, they have to approach the court to get the permission.
Yeah, the caretaker has to approach the court.
Yes,
Caretakers have to approach the court, and they have to. And most of the time, the court rulings in these cases are very sympathetic towards the victim, towards the assault survivor. And normally they do opine for termination.
While preparing for this presentation, madam, I went through some cases. They had for rape victims for even 12 years, 13 years. I saw some court proceedings like the baby's gestation age is around 28, 30 weeks. So as sir told, respecting the fetus life, the termination was overruled. So I think
termination was denied. This has happened for a very young teenage girl. Yes.
Yes, madam. Yes,
Yes,
madam. For 12 and 13.
13-year-old girl. When the
Yes,
pregnancy was into the third
32
trimester.
weeks. Yes, madam. It was overruled. They were denied termination.
So, Dr. Mahalakshmi, would you like to highlight what would you do while when you want to terminate this kind of a pregnancy in a mentally retarded? Would you like to go by case and what the things that you will expect and in what way you would like to counsel the patient, the caretaker mainly, because
First,
she is a mentally retarded patient.
Net connection was interrupted, ma'am. So, ma'am.
Yes,
Can you hear
go
me?
on, go ahead, ma'am.
Yes, ma'am. Yes, ma'am. So, women with mild mental retardation, that is IQ scores between 50 and 70, they may be able to make some independent decisions with some support and guidance. But however, the level of independence will only depend on the specific situation and the women's individual abilities and limitations. Women with more severe forms of mental retardation, that is IQ score below 50, they require more significant level of support and assistance in making decisions. So,
yeah, below 50, they will come under the severe MR category, and
yes,
I think they are incapable of making any decisions by themselves.
Decision.
Yeah, so
yes, so a mentally retarded person has to be referred to a psychiatrist. He has to calculate the IQ of the client, and he need to be counseled and rehabilitated by the psychiatrist. And therefore, when a person's IQ is less than 50, they are as such incapable of forming an independent decision. So as such persons are incapable of giving a valid consent as their minds are not fully developed to understand things which a major is required to understand. So if Saranya is found to have severe learning difficulties and continuing of her pregnancy is not in her best interest, then with the consent of the guardian, termination of a pregnancy can be done. The fact of a pregnancy should be documented and informed to police. Products of conception should be preserved in saline and handed over to the police for forensic lab testing and legal procedure.
Yeah. So in a mentally retarded, when you're going for a termination of pregnancy, so this is the most important factor, which she has highlighted in her slide, that the person is with her learning difficulties, she's continuing the pregnancy. When you want to terminate, the consent of the guardian is very important, and the documentation is important, informing the police and sending the
preservation of that is very important,
so
because this
important.
is something where it is a repeated offender sometimes. And if we are not able to identify the culprit, then she might end up having another episode like this. So we have to be very, I think, take a very humanitarian approach towards this unfortunate, victim, and give her as much justice as possible. And what Vivek sir said, that we have to definitely do the as per the law, preserve the fetus and send it across. But if it is a viable pregnancy, then what are we going to do, sir? She's going to have a live birth.
Yeah,
with whatever mode of termination we offer her. Then
in that case, there's a guardian, no? The guardian takes care of the child. The one important thing which I would like to say is, many times the court gives responsibility for the doctor to take the decision. See, that we feel this patient has no mind to take a decision. So in that case, the court feels that the doctor should be the best friend, should act like a best friend and take decision for the patient. So it's in one of these conditions, the doctor's duty to take decision. Most of the time, it is the patient who takes decision, remember. But whenever the mental ability of the patient is subnormal, sub-average, it is the duty of the doctor to take a good decision on the behalf of the patient. And that decision is acceptable in the court.
Thank you, sir. And I thank all the panelists. I hope you enjoyed the panel, and so much of cases only we could take 10, and we asked Rajashree whether we could find time, and she said you can go on till 7, but it's time for us to close, and we really enjoyed being a moderator, myself and Dr. Mahalakshmi. And I thank Dr. Mahalakshmi for taking the real cases from ISO and government KGH. Thank you, Maha. And I thank all the panelists once again, and special thanks to Dr. Vivek Madi for joining us in this program. Thank you, Dr. Rajashree, for giving me the opportunity. Thanks a lot.
Thank you so much. Thank you so much.
Yeah.
There is one question, Geeta Lakshmi. 21 weeks cleft palate potrukanga.
So when there is an anomaly in the fetus.
It's not
Madam,
a lethal anomaly.
no. Cleft palate is not a lethal anomaly.
It's not a lethal anomaly.
So we cannot, and with the advances that we have in plastic surgery nowadays, they do staged procedures for correction. Yeah. So I think for non-lethal anomalies, we should not offer termination. Unless it is
you can counsel them for the anomalies, either chromosomal anomalies associated is there or not.
Yes, if there are, if it is syndromic.
Yes, if it is a syndromic, you don't find any chromosomal aberrations with the cleft lip. Sometimes it may be associated. So you have to rule out the chromosomal abnormality. If it is there, then you can recommend. Otherwise, genetically normal baby with just because of the cleft lip or cleft palate is very much correctable.
And when she has said 21 weeks, the option we can give is an NIPT at this stage to look at, to see whether there is a possibility, as Jairani madam said,
no,
about the chromosomal thing.
I want to differ from you. NIPT, they will be definitely giving 98%. But you go for an amnio. 21 weeks, you do an amnio, see a fish. You see a fish, that is more informative and more corrective. And you are more ascertain of all the things. That's very important.
Yeah. I thank our president also for being with us. Thank you, Dr. Jairani. Thank you, Vivek sir, Vijay, Rajashree.
Gives me great satisfaction to propose a vote of thanks.
And Vidya madam, my panelist, Dr. Karthika Prabhu.
Thank you.
Wonderful.
I would like to thank, first of all, our
Oxy, thank you, Oxy.
President, Dr. Jairani, and our efficient secretary, Dr. Kundavi, for encouraging us all month on month to do webinars like this. Okay, it is through their encouragement that we are working on and doing. I would like to thank MC Patel sir. We are really honored to have you, sir, and your contribution in this field, especially for us gynecologists. It has been immense and revolutionary. You've been always available. Like Madam said, you've created consent forms, and really thank you so much for making time to be with us today. Bharti madam, yes, you have, in spite of being busy, you're able to log in and give us your inputs, and you have done a lot of work as when you have been the chairperson of the MTP committee, and we have that Foxy Focus where you have been the editor, and it's really a good handbook that we have had. Shanti madam, you are truly an expert, and thank you so much for your valuable inputs. You enlightened us on many of the practical points. Our President Ma'am, Jairani Madam, and Dr. Meena, the MTP amendment was really, truly decoded. It was done in a systematic way, and each and every point was explained in such a way that all of us could understand it. It was done in such a simple language, step by step. It left nothing to be answered. You had answered everything. And our two young members, Neha and Nitya, yes, it was an exhaustive and concise talk done on time. Evidence-based, I can always have them. I always have them on my side and pat them on their back. And finally, the panel, Dr. Geeta Lakshmi and Mahalakshmi, various case scenarios. You've really taken the time. It is really special situations. Can't think of all this put together, and they are real case scenarios. You have taken the time to go through and get it into a form. Yes, a great effort done by you. and the panelists, yes, each and every one of us, to make it an interactive session. Dr. Geeta Lakshmi, Dr. Karthika, Dr. Vidya, Dr. Vijay Lakshmi, for putting in your inputs, and Vivek, definitely, yes, you are an added one for all, a very important person in the panel to give your opinion on each and every case regarding the legal aspect. And thank you for your time. You told me you're out of town, but you will just be able to log in and take part in the CME. Thank you so much. Finally, I would like to thank Shield for the platform provided, Sneha for being an excellent mock, and our delegates who encourage us month on month by attending this and allowing us to do more and more webinars. Thank you so much. Thank you.
Thank you, Rajeshri, for
Thank
this
you.
nice, wonderful, compiling
On
everything.
behalf of all the panelists, we would like to thank our moderators, Geeta Lakshmi Madam and Mahalakshmi Madam, and Oxy, Jairani Madam and Dr. Rajshri Madam for